Good afternoon, everyone, and welcome to our Research and Innovation Conference. Today, I have the pleasure of introducing Dr. Benjamin Vipler, who is in the hospitalist division here at UC Health, to talk about transformative learning in GME, COVID-19, and beyond. Ben originally hails from the horse country of upstate New York. He completed his undergraduate and medical school studies at the University of Miami, Florida. After medical school, Ben went on active duty in the United States Navy, completing his residency, achieved residency and internal medicine at Walter Reed Medical Center. After his chief year, he moved to Virginia Beach, where he worked as an academic journalist and served as a residency associate program director. After finishing his active duty commitment, Ben completed a general internal medicine fellowship and master's in education at Penn State. Currently, he works as a hospitalist at the University Hospital and serves as assistant director for the Inquiry Longitudinal Integrated Research. As you will hear shortly, Ben's scholarship interests focus on transformative learning theory in medical education. He's an avid mogul skier, not me. That's wonderful. If anyone is interested in hitting the bumps with him at an epic before Breckenridge closes for the season, please let him know. Ben, wonderful to have you.
Thank you so much. For the folks on the camera, I will be wandering around the room. It's kind of my style to try to engage the folks who came here. Thank you for coming in person. It's good to be back. So I'm going to start with, conflicts of interest. I have no disclosure. Some of the scholarship in this talk has been funded by internal grants at Penn State. But I'd like to start off with a story. Some of you may have heard this story. You follow me on Twitter or recently published in Academic Medicine. So I was in my chief resident year, sitting in general internal medicine clinic, and I had a patient come in, and I sat down and saw the patient in the chair and knew that I knew this man from somewhere. Didn't know where I knew this individual. He had no recollection of me. Like to think I make an impression, but it is what it is. So I pulled up the medical record, and this was back in the military, so we had pretty much every clinical contact that this patient had in there. So I searched notes by my name. I didn't see any. Ultimately saw a CT scan of his chest that was ordered by me 3.5 years earlier. So I was an intern on the inpatient cardiology rotation, and I had ordered the study. Turns out, looking back through the record, the patient had come in at the time for acute chest pain, ultimately was diagnosed with severe coronary artery disease, but due to some life situations, had to go home, get some affairs in order before coming back for an elective procedure. So some of that study was notable for a few abnormalities that we noticed during that admission, and the patient had a follow-up appointment to address those abnormalities in the outpatient side. That information was in the patient's discharge summary. We informed the patient of that. And the patient was discharged, came back for a surgery, and left. So as I'm reviewing this medical record, as I see the patient 3 years later, I noticed some of these abnormalities that were never followed up. So my heart sank first, because I was the ordering physician. But then I did two things. One, I ordered the necessary follow-up, even though it was delayed. And two, having trained in a culture of safety and quality improvement, I submitted a patient safety report. I thought that there were multiple systems and individual issues that led to this patient's delay in care. Didn't hear anything about it for months. And to my surprise, the next time I heard about it was an email to me saying that my credentials were reviewed for not meeting standard of care. And ultimately they were reviewed and deemed that I did not meet standard of care, but my supervising faculty did. So this was a big shock to me. This was very distressing. Ultimately, I went to my family, I went to my friends, I went to my mentors, went to my former program director, who was during my chief resident year was my boss, and said, this is not right. This is, my whole worldview is questioned. What's going on here? And we worked the problem. We called the committee to reconvene. I stated the case. We looked at all the issues and systems breakdowns there. And thankfully, the committee reversed their decision after hearing the full story. But I definitely learned a lot from that experience. If you want to read a little bit more about it, this was recently published in Academic Medicine in one of their narrative medicine pieces a couple of weeks ago. But I'll ask you, what did I learn? I definitely learned, but what did I learn during that experience?
Knowledge.
I did. I learned knowledge. It was probably knowledge I didn't want to learn about how the system was working. Good. Probably not so much skills.
Well, you could have learned that it wasn't safe enough to submit patient safety reports.
Right. That's the hidden curriculum. It wasn't safe enough to submit patient safety reports, right? Prior to submitting that, I was told over and over and over again that this is for system improvement. This is not punitive. Definitely learned that that was not the case. That was another knowledge point. How about attitudinal learning? It's definitely changed my attitude. And I would really group this into that bucket first and foremost. I think I was definitely a different person. I definitely practiced different afterwards. And this is something that to this day impacts my practice. But it impacts it in the way that was said earlier. I learned that the way that we did things was probably not the right way. But it changed it in a more empowering way. How do we get to a better system? How do we get to a place where we can improve systems without, with due process, with just culture? And ultimately, I think that this inspired me to move in that direction and to empower people in the quality committee. I'll say after I published that article, I met with the chief quality officer of UC Health because she was interested in my views on that. And I think that's one step towards improving the system. Even though it didn't happen here, people are interested in that. That brings me to the next question of how do you teach attitudes? And I think teaching attitudes is important. If you look at CU's website, I'll pull up a couple things because this is small. We want to teach people to have a commitment to decreasing health disparities. We want to increase health equity. We want to transform the healthcare landscape. I mean, this isn't something that you can necessarily do by getting a board review course or sitting in a lecture, or I'd argue even team-based learning or problem-based learning. I think that there's something else that we can look into. And that's what brings me to transformative learning theory, and that's what interested me during my fellowship and master's about this learning theory. So our goals for today: understand the theoretical framework of transformative learning theory, and differentiating that. The word transformative gets thrown out a lot in medical education and education in general, but what do I mean when I use capital T, transformative learning theory? Analyzing transformative learning experience in graduate medical education. So how do those look? And then we had a very transformative experience, all of us experienced together, called COVID-19. And what takeaways can we have from that and apply to other future experiences that we have in the clinical setting? So the experience that I framed up front, I think for me as a clinician, it was the most transformative experience I had. But how do I fit that into a distinct theory? So I'll give you a couple definitions of what transformative learning theory is. And as you hear these, think about the story I told, think about some of your experiences that you had, and whether you went through some of these steps and whether or not you had the outcomes that I described. So this is the most broad definition, but I tend to like it the best. It's learning that shapes people. They are different afterwards in ways both they and others can recognize. So it was brought up the hidden curriculum a little bit before. So for the Stranger Things fans in the audience, I kind of look at the hidden curriculum as this like unspoken attitudinal change that typically is negative or the upside down. And then I say, I don't know if it was called the right side up in there, but just the real world, the positive experiences that we can get out from some of the same things. Whether you see something, it disorients you, whether you take away something that is negative or something that is positive after it, is sort of how I frame this. You can get a little bit more granular with it. So this theory was originally coined by Jack Mesereau in the 70s in the adult education community. He was out of Columbia. And he really broke it down into 10 steps. Now, these 10 steps are not necessarily all required, but I'll highlight one here, experiencing a disorienting dilemma. So in the story that I told, I was definitely disoriented when I got this email and had this experience. And that really sparked this whole cascade of change in my life. There are multiple other steps. I won't get into all the 10 here because others have broken it down into 4, and I find that a little bit more palatable. So we have this disorienting dilemma. The first thing we do is internal reflection. Take a step back and say, what is going on here? Sometimes that reflection needs other people to help make sense of your life-changing experiences, and that's where this discourse is. So using other people, some internal reflection, and saying, I had these previously held assumptions that I thought were right. I lived by them. I thought that that this was a safe space to present patient safety issues, and we could all, as a healthcare system, improve afterwards. And that assumption seemed to be incorrect. So I had to speak with colleagues, with mentors, with friends, with family, and ultimately change my worldview. And that's what the action is. So ultimately having some sort of change in your worldview, whether that's changing yourself, whether that's changing the culture around you. Oftentimes, or I should say, the literature says it does need to be positive to classify as transformative learning, which is why I put that hidden curriculum slide up there. Okay, please.
And I was thinking about what you said. You could go from a disorienting dilemma and then reflect critically, but instead of going the right direction towards a rational discourse, you may look into something that's a lot more negative and harmful.
Right. So a lot of the research in the adult education community around transformative learning after disorienting dilemmas sort of backtracks. They see people who have done atrocities in the world, whether it be dictators or whether it be mass murderers, if you will, and sort of take a step back and say, was there a disorienting dilemma, but instead of going a positive route, it went a negative route? Yes, great point. Now, I framed this at the beginning as teaching. So for the educators in the room, if our goal is attitudinal change, if our goal is to create health systems that are more equitable through attitudinal change, how do we foster this? But before we talk about how to do it, or if we can do it, because that's still debatable, I want to talk about, is it our right to do this? So what right do I have as an educator to encourage you to question what you believe? When is it a responsibility and when is it an imposition? When is it empowering and when is it destructive? So this is a quote by Patricia Cranton, who she really broke down transformative learning into different processes. So whether it's an internal process, whether it's something that you do for social justice, whether it's something that's subliminal that happens through dreams, just for context. So as I mentioned, transformative learning has been in the adult education literature since the 70s, but only recently in the past 5 years or so have I started seeing things in the medical education literature. So I was curious about that. Are we calling this something different? Are we doing it? Are we not? So the first literature search on transformative learning was by Susan Van Schalkwick's group. And this was mostly this was all undergraduate medical education, about 50% nursing programs. This was published in 2019. And I'll highlight a couple things here. Very similar to what you'd all imagine, they concluded that the healthcare system and medical education has a lot of unfamiliar experiences. There's your disorienting dilemma with uncertainty, again, disorienting, complexity, disorienting, question what we believe, disorienting, and again, from medical education, nursing education, across different domains. But when I was reading this, they said, to the best of our knowledge, this is the first review, but we excluded anything that was not undergraduate medical education. So I, along with a couple of my colleagues, sought out to see what does this look like in the graduate medical education world. So we published this review in GME, Journal of Graduate Medical Education. And we approached this a little bit differently than they did. So I felt it was a bit odd that transformative learning was in the adult education literature since the 70s, but we've only been seeing it recently in the medical education literature. So I really sought out as well to find out, are we calling it something different? So if we had an article that mentioned quote unquote transformative learning, we screened for it or we included it in the study. Or we had multiple independent reviewers look to see if the articles that we polled had the 4 components of transformative learning theory. Was there a disorienting dilemma? Was there critical reflection? Was there discourse with an educator or guide? And was there some sort of action afterwards? And if that was the case, we included them as well. So I trimmed this talk a little bit down, thinking that there was going to be someone coming after us. So if you wanted me to dig more into the methods here, happy to do so. But a couple of themes that we found out in this review in graduate medical education as it related to transformative learning. A lot of the literature surrounded professional identity formation as well as professionalism training. And I think going back to the can we teach attitudes question that I led off with, if anyone struggled with a learner who, or anyone worked with a learner who has struggled with professionalism, oftentimes we think the fix is something attitudinal. So there was a lot of discussion on there. As far as professional identity formation, which I'll say is different than professionalism, that term comes up a lot of what does it mean to be me as a physician, to be me as a researcher? And that kind of looked at the end goal of I am a student now, I'm a resident now, at the end of the day or at the end of training, I'm a physician, I'm a researcher. What's the process that we took to get there? And a lot of the articles pinpointed transformative learning or transformative learning theory as the stepwise approach to embody that new professional identity. Almost all of the articles that we found were in the primary care domain. I'll pause there. Any thoughts why that might be? I'm still trying to figure this out. We proposed a couple of ideas, but why do we think that transformative learning in the graduate medical education literature kept coming up again in primary care specialties? And this was not just the US, this was in GP residencies in the UK, all over the world.
Transformative learning requires like continuity or time. I don't know.
Yeah, I think that's great. I agree. I think that in order to, the transformative learning literature says, in order to have a change in assumption, this may seem obvious, you have to have an underlying assumption. So some sort of longitudinality, I think, is definitely a component that could play in here. Getting to know a patient and then having some sort of disorienting dilemma with that experience. As I mentioned earlier, we are calling transformative learning by other names. Professional identity formation, even though it's seemed to be kind of the end goal of the process of transformative learning, was used often interchangeably. There were also other interrelating theories of communities of practice, of the hidden curriculum, which is why I came up with the Stranger Things diagram. So giving the language to transformative learning was something newer, but I think it's been occurring and we've been fostering it for a while. And then anytime I do a literature review, I like to see what's not there. And I think that the diversity, equity, and inclusion literature was rife with disorienting dilemmas. But often these papers were excluded because they didn't have the second, third, and fourth step of transformative learning theory. There was no critical reflection, there was no educator guide, there were no venues for discourse, and ultimately, sadly, often not action. So if we want to transform attitudes, if we have a method to transform attitudes, is there a way to measure whether attitudes are transforming? So interestingly, at the institution that I happen to be doing my fellowship, a couple of colleagues within my own division had actually, I found this independently via a literature search, had published the most widely used data collection tool on assessing for transformative learning. And then COVID hit. And as I'm sure many in this room, derailed clinical experiences, derailed research experiences. But you know, when you're hitting your head against one door and another door opens, I went through the second door. So I saw COVID-19 as one of the biggest disorienting dilemmas that we'll ever experience. There was a decent amount in the transformative literature after September 11th written about that as a societal transformative experience or societal disorienting dilemma. Excuse me. Historically, most of the disorienting dilemmas that are cited are very individual, whether it's being a victim of a crime, whether it's losing your job. So I was definitely interested in studying these experiences that are presumably disorienting for large numbers of individuals, and ultimately seeing how different people have different experiences with that. We did a couple studies in this domain. The first was a mixed method study using Dr. Stuckey and colleagues' data collection tool. And we were interested in medical students, PA students, residents, and fellows, how COVID-19 impacted their basically lives, how it transformed their lives, and we wanted to know how it did it, what were the outcomes, and what were the processes of this. And as we go through this, I don't intend to study COVID-19 anymore. I know many of you don't as well. But think about how we can use some of the principles that we discovered in this to apply to other domains of research and medical education. So as I mentioned, these were our aims, looking at the processes and outcomes of transformative learning in the populations there. And this was a single institution study. The transformative learning survey that Dr. Stuckey created, fairly long, about 90 items, Likert scale type items, as well as 2 open-ended questions, which were designed to be modified by the end user, or by the survey user. So the 2 open-ended questions that we asked were, in what ways have COVID-19 altered your life in a meaningful way? And describe this experience with COVID-19. Was, or how was it life-changing? Who was involved? In what context did this change occur? And then we also wanted to see the differences in numbers of quotes that fell into each coding category. And then also look at the difference between house staff experience and medical student experience during this time. For numbers, we grouped medical students and PA students together because they were mostly preclinical. And we grouped residents and fellows together who were in the clinical domain. Because as you probably recall, most of the medical students, based on double AMC recommendations, were pulled from clinical experiences. So traditionally they would be in clinical experiences, but during this they were not. So a couple of highlights here. As far as transformative learning outcomes, the domain that was most commonly seen across the study population was self-awareness. So being involved in this pandemic increased their own self-awareness of their own beliefs, of their own values, of their own underlying assumptions. We hypothesized a little bit about whether this was lockdown, whether this was being at home with your feelings and families and cats and nothing else. And then the processes, I cut a little bit of this out at the beginning for time, but the processes that one can go through to have an outcome of transformative learning, the cognitive rational process is that 10-step or 4-step Mesereau process of the disorienting dilemma, critical reflection, rational discourse, and then action. Social critique is a very similar process, but as I mentioned earlier, at the end, it's not you that's changing, it's society that's changing. So if we look through the medical school lens of how do we create enlightened change agents to improve the medical system, that's the domain that we're looking at. This extra rational domain there at the bottom is a little bit more esoteric, a little bit more in the humanities domain, but how can I adopt new worldviews without consciously going through that process? If I saw a piece of art or heard a new song, or and that changed the way I saw things, but didn't really take a step back, reflect, and but I was a new person after. If I had a dream or an epiphany that changed my worldview. Not surprising that one was seen less commonly. How did students and house staff experience transformative learning differently during the pandemic? So one thing that I'll point out is that students, so for those more involved in undergraduate medical education may be interested in seeing this, were more likely to undergo transformative learning through the social critique process than their residents. So I don't know, any thoughts on that, why that might be? I have my thoughts, but why would students be more likely to be transformed through COVID-19, mind you, in the social critique process. So jumping back, like why changing the world is the ultimate outcome as opposed to changing yourselves.
I mean, I think maybe it sounds a little bit negative, but is there a level of idealism that you tend to lose moving from medical student to residency and attending physician?
Yeah. So that was one of my take homes from this study is that how do we, granted it's a hypothesis, but it was ours as well. How do we try to prohibit or combat that loss of idealism or that becoming jaded in the graduate medical education space? If something like COVID-19 can do it, anything can do it. Medical training can do it. So for our content analysis, again, reviewing those first two open-ended questions, we coded them according to positive change, negative change, existential change, and no change. We, after the fact, looked through, and the only change that we really felt could be transformative learning was this existential change. And I'll give a couple of examples of that through exemplar quotes. One member of the House staff said, COVID-19 showed me how leading medical experts and institutions have little to no interest in operating on an evidence basis and adapting as more information is acquired, and instead are more in favor to conforming to an underlying social moral. And the student said, COVID-19 opened the discussion for structural racism in the healthcare setting, as well as other settings, and I became more aware of what it is, of what is going on, and more vocal about what we can do to change it. So going back to not losing our sense of purpose. Negative changes were more frequent than positive. More frequent than positive, existential, and no change. Again, not surprising, but it was at the time, not surprising now when we think back of it, but it was at the time. There was a lot surfacing about how positive healthcare workers were during this early time and posting about camaraderie and we're in this fight together. But in an anonymous survey, the results showed different. Again, single site. And then more negative responses were coded for students than house staff. So I don't know. This maybe counteracted our thoughts about the idealism there, but we caveated this with a lot of the frustrations that came up were from being pulled from clinical activities, where they're in school, they're paying for school, and they're not seeing patients. So that was the first study we did in this domain, but we wanted to dig further. We just got such great stories, but it was like 2 open-ended survey questions, and we wanted to dig more. We wanted to see if and how residents and fellows engaged in transformative learning theory through their experience with clinical care of COVID-19 positive patients admitted during the initial peak. So the first study looked at everyone in the hospital. It was still very early on in the pandemic, I might add. At that point, there were only editorials and narrative medicine pieces written on this and brief interviews, but not a ton of formal research done on it. But what were the experiences of these residents, many of whom participated on a volunteer basis, residents and fellows who participated on a volunteer basis with direct care of COVID-19 positive patients? This is the second paper we published in Teaching and Learning in Medicine, and we called it A Graphic Transformation, Qualitative Study of Transformative Learning in Medical Trainees During COVID-19. And I'll key into that last little bit there using comics as data presentation. So we'll come back to that. But it was a qualitative interpretive study. We used semi-structured interviews, interviewing Penn State house staff, caring for COVID-19 positive patients during our county's first peak. We had 6 participants, 4 residents, both medical and surgical specialties, multiple institutions within the training program, and 2 fellows. Individual interviews were about 45 minutes to an hour, and we conducted a thematic analysis. And the 3 themes that we came up with were a sense of guilt, the impact of COVID-19 on training, and then venues and processes for reflection. But we all heard a picture is worth 1,000 words. So I'm not going to go into each one of these right now, but what I will do is show you some graphics. So a colleague of mine at Penn State, edits for the Annals of Internal Medicine graphic medicine section. and he was looking for, at the time, completely independently, looking for frontline healthcare workers who had just great stories of working with patients who were diagnosed with COVID-19 early on in the pandemic. And I saw his call for these stories, and I said, wait, I have 6 hour-long interviews of great stories. So we edited our IRB. We got him involved, and instead of doing a thematic analysis, we included exemplar quotes in our paper and text. But one thing that we wanted to do was include a graphic that we felt summed up that entire theme in a 4-frame comic. So I'll show you those right now, and I'll read them for you. When people heard I was a doctor, they'd treat me like a hero. You're a frontline worker? Nah. I'll give you a discount anyway. Thanks for what you do. I'm literally doing nothing while some kid in India is knitting masks with his feet. They made me sit at home on my hands so I wouldn't expose myself and then call me a hero. I hated it. So the whole first theme was we were about a low to medium volume center. And we pulled a lot of learners out of the clinical learning environment for quote unquote safety. But they had a lot of moral injury and mental distress from this experience. A lot of similar things that we see in survivor's guilt, and a lot of the literature we cited in this paper were around surviving spouses, surviving veterans, and others in their unit did not. Again, the theme for this one was the impact of COVID on training. During the pandemic, if a patient with COVID came in with appendicitis, we probably wouldn't take them to the operating room. This isn't the usual way it's done in the US. But at the time, it seemed better than exposing the whole surgical team to COVID. It altered our opinion on how we manage surgical patients in general. Do we really need to take all these patients to the OR, or these people to the OR? It's life-changing when you take a step back and realize there are a lot of ways to manage patients. So what's interesting is this trainee knew of the articles that said that we can treat often appendicitis with just antibiotics without surgery. But we don't do that here. But it took this experience of actually seeing us do this, seeing these patients, to have this learning experience that there may be other ways to treat patients other than just the way that we always do it. This was the processes and venues for reflection theme. So there's kind of 2 stories. There's the top 2 and then the bottom 2 that relate. So the top 2 is the fellow's experience, and then the bottom 2 is us chatting during the research interview. Pre-COVID, I had a monthly meeting scheduled with our head chaplain as part of my fellowship program. Meeting today? Let's cancel. Too much going on. Okay, maybe next month. Then the pandemic hit, and we began to meet more frequently. Whoa, our hour is already up. Can we have more time together? So that was the first venue for reflection. So need for reflection. So seeing that with COVID, the whole need for reflection increased, and a venue that was already there was capitalized on. So we did our interviews about a year after the time in question, and multiple participants in our study really recognized at the end of our 45 minutes to an hour together that just that interview was really the first time that they reflected on it, the research interview itself. So 1 year later, these conversations made me think a lot about the past year, what the past year has been like, and now how different things truly are now. I was surprised because even though I had been immersed in COVID, I hadn't thought much about all that had changed until this interview. I think I took multiple implications for practice from this study. One is we put a lot of emphasis on the front lines versus the sidelines in the COVID-19 pandemic, but not forgetting that there may be some underlying mental distress or moral injury from those who had to sit on the sidelines, who were forced to sit on the sidelines. Giving ample reflection venues, oftentimes meeting people where they are is better than having them come to you. I know how we all feel about mandatory wellness. And then finally, can we foster transformative learning as a pedagogy? So to circle all the way back to the beginning, can we use transformative learning to create attitudinal change? And I'd argue yes, and I think that key point in there is maybe the discourse. So they may have a disorienting dilemma, they may have some internal reflection about it, but to move them from that critical reflection to embodying new assumptions that are ultimately more positive, more equitable, does take an educator or a guide or a mentor. And I think that's where we can come in. Where do we go from here? So I showed the shattering glass and the disorienting dilemma and the COVID and the derailed research. Prior to all this, I had during my time as an associate program director for a medicine residency, I chaired the clinical competency committee, which is like the promotions committee. And I noticed that there were residents who struggled, and we would create a very intricate remediation plan and assign them mentors. And often the things, and this was true for us and what the literature says, often the things that are in these remediation plans for struggling learners are just more of the same that didn't work the first time. And trainees would often check the boxes, do everything that we would ask, and then 3, 6 months, 1 year later, they'd be back being reviewed by our clinical competency committee again. On the other hand, there were learners who had oftentimes a disorienting dilemma just by being brought in front of the clinical competency committee or being put on remediation plans. Like, wow, something needs to change. I need to reflect on my life. I need to find out what are these competing commitments that are prohibiting my growth, and work with my mentors and guides to get there. And we saw, again, a separate population of trainees that it was almost like a switch flipped, and they were just different people afterwards. So we wanted to dig into this. And one of the frameworks we used was the immunity to change model. So this is a book by Keegan and Leahy at Harvard, who really gives you a framework of how to dig into what are those competing commitments that prohibit you from changing your worldview, from changing in a positive direction. So my next endeavors are to use this framework in struggling learners and hopefully transform them. So I'll end there with ample time for questions, and thank you.
Did you say that for the last study you showed us that you did, all the people interviewed were volunteers?
Mm-hmm.
So
volunteers for the interviews or volunteers for COVID?
No, volunteers for COVID.
Yeah.
So do you have any idea of how, like, for example, here where we didn't have residents volunteer, we actually put them on wards? Like, do you have any idea of how different that transformative experience might be?
Yes, that's a really interesting question. I think even within our volunteer cohort, they were still people who felt like they wanted to do more, and some who, it wasn't a major theme, but some felt like they wanted to do less and were concerned for their own health and safety. I think that it would definitely fall more in the latter domain of concern for the health and safety if it was out of your control. I don't know much about if it decrease the moral distress if you were in a high volume center, just because of how sick the patients were and how close you were for death, close you were with patients who were dying. I think our takeaway was more of not to forget that there may be distress on the sidelines.
Any online questions? More question.
Has anyone here had a disorienting dilemma that resulted in transformative learning?
Yep. I actually left medicine for like clinical medicine after COVID, and I'm just coming back.
Wow.
But I was thinking about that while you were talking and how that all unfolded.
Do you think that you can foster disorienting or foster transformative learning? It's still being debated today. I'm in the yes camp.
I feel like you can, like, having worked with learners for like the last 15 years, I feel like that's kind of the, like, for me, that feels like, I haven't used these words around it, but that for me, that's the like rewarding part of working with learners, that you do that. So I think you can.
Yeah, I think so too.
Can you say more about, sorry.
Oh, no, please.
Can you say more about your plans for implementing transformative learning with students in the future?
Yeah, so I hit this slide, but I'll pull it up here. Can I go to this? Is it on that? Oh, there it is. So this is, thank you. So this is, we often encourage mentorship and coaching, but don't often have like a very simple guide to leading those sessions. And this is one that came out of that immunity to change model of how to create that change and really dig behind some underlying assumptions. So I'll read some of the points here. So up in the top left, you have your improvement goal. So this is looking at the focus of a struggling learner that I wanted to change. Or if your improvement goal is a systems improvement goal, or I want to create a more equitable admissions department or process, whatever that is, what's your improvement goal? So the next is getting a little bit more granular. What do we need to do differently in that? So the example I have here is I have a student or a learner who's struggling with getting their notes done in time. I want them to complete their notes faster. And this is a purposefully simplified example, just to sort of see how the process works. What do I need them to do differently? Get their notes in before noon so consultants can read them, so they can do other things in the afternoon. What are my behaviors that go against my goals? My notes are way too long. But then asking the why question. What are my hidden competing commitments? I'm worried that if my notes are not long, my faculty who evaluate my notes are not going to like them. And they may not know, without sitting down and really spelling it out, that the reason their notes are so long is because they're scared of their evaluations. They may not, but using this framework to get there. So what's the big assumption behind this? That the faculty like my long notes. I'm a faculty member, I don't like long notes. So getting to some of these underlying assumptions and challenging them and creating them. Again, an oversimplified example, but using this as a framework with learners struggling in every domain. Some of the times where transformative learning theory has come up in struggling learners is in the domains that we think of professionalism, systems-based practice, a change in the healthcare system, practice-based learning and improvement, improving myself in my own personal practice, something that you can't really do just by opening a textbook or going to a board review course. Great question, thank you.
Can transformative learning only be applied to those that have experienced, a challenging momentum in their life? Is that the only way it works?
Yeah. So I would say no. So this I mentioned the cognitive irrational domain. So this is the 10 steps or 4-step process that starts off with a disorienting dilemma. I mentioned the social change process, very similar, but the ultimate goal is not changing myself, it's changing the system. I think this domain, the beyond rational or extra rational, where we mentioned epiphanies, insights, dreams, a lot of the transformative learning in this domain, transformative learning literature in this domain is written about religion and spirituality. I don't necessarily know why I changed, but I feel different afterwards, and often it's addressed to a higher power. And may not be necessarily related to a disorienting dilemma, but people are different afterwards. So I think no. I think that one's harder to foster. So as a medical educator, that's one that I pay attention to a little bit less, but is definitely one that has been written about a lot in the medical literature. Going back to whether or not you need a disorienting dilemma, there's another question that comes up often of whether or not we should capture ones that are already there, or whether or not we should create ones. So I'm writing a paper right now with a couple of colleagues looking at humanities and using them as disorienting dilemmas. So using a movie as a disorienting dilemma when someone is a victim of a crime. So not necessarily you experiencing that, but can you use external media to do that? Because we don't always have disorienting dilemmas that are like readily available. We have a lot. Again, some of the early literature in transformative learning and medical education was about international health electives and working in underserved areas. So can we create those experiences? I mean, international health electives can be expensive and resource heavy. So if we don't have those, how else can we create these dilemmas to foster this cascade?
Thank you.
Thank you.
Questions? Thank you so much.
Thank you.